right, so we'll go ahead and get started and kind of let people in intermittently as we go through here. So thanks for joining us today. So my name is Cameron Hilt, and I currently serve as the new program director for the Upper Midwest Telehealth Resource Center, as well as the Crossroads Partnership for Telehealth, which both of these programs are programs of the Indiana Rural Health Association. So we really wanted to take the time today to be able to talk to you about a particular program that we developed that we're currently looking for funding for. The model of the program is focused on integrated virtual primary care and behavioral health. So as I said before, I currently serve as the program director for Crossroads and the Upper Midwest Telehealth Resource Center. I had the pleasure of working with Becky for over a year, serving as a data and evaluation coordinator for the Upper Midwest Telehealth Resource Center. Before coming to these positions, I worked as a population health consultant. And really that's where I first got to have a lot of my exposure to telehealth and ultimately the impact it can have on patients. So I want to go ahead and hand it over to my colleague Bryce to introduce himself and to kick off our presentation.
All right, thank you, Cam, and welcome everybody. Thank you for taking time out of your day to learn more about this program. My name is Bryce Wray-Nelson, and I've been with the Indiana Rural Health Association for about 3.5 years now. I serve as the project coordinator for the Crossroads Partnership for Telehealth. Before that, I also worked with the Indiana Rural Schools Clinic Network, delivering telehealth to our rural schools. I also have had experience with Community Health Network based out of Indianapolis, and before that worked as a medical scribe in the emergency room with Community Health Network, which was a very interesting experience. All right, to go ahead and get us started off, we have this little disclosure. So all of the Crossroads programs mentioned in this presentation are funded through the Health Resources and Services Administration. There are no conflicts of interest to note, and the information, conclusions, and opinions expressed in this product are those of the authors and is not an endorsement by FORP, HRSA, or HHS. All right, so let's go ahead and give you a brief overview of the Crossroads programs that are currently operating. So Crossroads 1 is obviously the very first iteration of the Crossroads Network for Telehealth. It started in September 2018 and will sunset in March of 2022. It has a hub and spoke model, telebehavioral health focus, with all of our partners being located in mental health professional shortage areas. And so as an organization that was given this money by HRSA, we provide annual stipends, help with implementation, and evaluation support for these programs. And then the data is utilized to build the evidence base for telehealth. And so a brief overview of some of these numbers here. We've had over 1,100 telehealth patients with over 4,200 telebehavioral health encounters. And this is all coming from our interactions with 4 partner sites across the state of Indiana. Next slide. Crossroads 2 was written for in 2020. We were awarded that in September, and that will sunset in August of 2024. And so this is an extension of the original Crossroads Network for Telehealth, and we still provide that annual stipend to our partners. We help with implementation and evaluation support. However, with this program, we work to really focus on telestroke or teleneurology consultation, teletrauma, and tele-EMS services. And the interesting thing about this program is that it can also include the expansion for telecardiology services. And so currently, there have been 68 telehealth patients with 68 telestroke encounters, and this is all through the partnership with 3 partner sites in the state of Indiana. Just a quick note here, this was very interesting to start a program in the middle of the pandemic. I do not recommend that. It was very interesting, very challenging, but through the working with our team and working with our incredible partners, we were able to get this launched, and we have a very strong start for this program. And so it's very exciting to have this active. Next slide. All right, Crossroads 3, and this is the program that Cam mentioned that we are currently seeking funding opportunities for. So this would focus on direct-to-consumer telehealth, would have the main focuses of primary care and behavioral health care, with secondary focuses being maternal health, chronic condition management, and substance abuse. And these, of course, are issues that we have seen in rural areas, and these are areas that we are very passionate about making a difference in. And then, of course, with the other two programs, data is then going to be utilized to build the evidence base for telehealth. Next slide. All right, direct-to-consumer telehealth. Just a brief description about this. This occurs when patients initiate an appointment and consult with a healthcare provider on their own device and on their own schedule. It can happen synchronously, so in real time, or asynchronously in terms of store and forward, depending on the goal of the appointment and the patient's needs. And a more descriptive definition is a subset of telehealth that shows promise in increasing access to and engagement in medical care. And then quality assurance, reimbursement, and regulatory oversight are important factors in assuring appropriate widespread adoption. Next slide. So we might be asking ourselves, why direct-to-consumer telehealth? Well, this reduces patient no-shows. And a very quick story about this. During the pandemic, within our Erskine network, one of our partners in Southern Indiana had a meeting with us, and we talked about their no-show rate. Before the pandemic and before the widespread adoption of telehealth in that community, it was about 30% average on a good day, I believe. And with telehealth, they were able to get their no-show rate down 0%, which I thought was an absolutely incredible example of how telehealth can positively impact a community if it's implemented correctly. It also helps to increase patient retention. So we know that today's busy world, puts up barriers. We're not able to get the healthcare that we need sometimes, and this allows us to really do healthcare on our own schedule. And so it also includes shorter wait times. Sometimes these appointments are cheaper, and it offers the patient more privacy. They're able to have that appointment from the privacy of their home, their car, in rural areas, from their combine, if they are able to. This approach also increases patient satisfaction and retention, which is going to lead to more revenue for a practice. This also leads to the fact that we can have new business opportunities through direct-to-consumer telehealth. So this allows providers to offer appointment times before or after the traditional workday, and it can also help to meet patient needs, extend billable hours beyond that standard schedule. You can also reach new patients, increase revenue, and expand healthcare beyond your immediate neighborhood or city. Next slide. So, in terms of primary care and behavioral health care, you're looking at lower costs to patients versus in-person visits for primary care. You reduce the barriers such as transportation, time, privacy, childcare challenges, and social stigma, which are some of the barriers that we've seen working in rural Indiana. We help to reduce avoidable ED visits. It helps reduce no-show rates, improved medication compliance, improved biometric control. And I think it's very important to mention here that with direct-to-consumer telehealth, longitudinal research is arguably limited. This is not something that's been around for, as long as other forms of telehealth. And so the research is still being done. There are pros, there are cons, there are studies coming out all the time saying that it's good, that it's bad. And I believe that only time will tell as more appropriate research is done and more time is invested in looking at the numbers and looking at the impact in our communities. Next slide.
All right, thank you, Bryce. So now I want to take us into the integrated care model and to give a little bit of an overview as well as where it kind of originated. So the integrated care model, some of the clear advantages, whenever you have two separate systems for primary care and behavioral health, there can be poor health outcomes, mostly because of that lack of coordination. So that kind of goes into the care coordination as well as the lack of follow-up. When you don't have that consistent communication between a primary care provider and a behavioral health provider, there's a lot of gaps that can happen within that context. And it can leave a lot of error for the patient, or kind of put a lot of the responsibility on the patient in order to need to follow up. So this integrated care model really helps to be able to provide that better care continuity for that patient to ensure that they're getting the best care and are having the best health outcomes they could. Some of the risks of some of those gaps, as well as it can lead to higher healthcare costs, especially when it comes to duplication of services. So when there's not that solid communication between providers, different screenings may be done multiple times, or information may have to be repeated from the patient multiple times, which can ultimately lead to poor care for that patient. So really one of the places where this originated was through the Cherokee FQHC in Knoxville, Tennessee. And so they were one of the pioneers for this type of model. And I thought that this quote that they mentioned was really impactful for what does it really take to build an integrated care model within your particular practice. And so they stated that integrated care is not just a program, but it is an ideology and a culture. So it takes more than just, I want to build an integrated care program. It's like we need to, as an organization or a practice, need to live and breathe this type of integrated care as a part of our culture. If you want it to be sustainable and last long term, that really is a huge piece in being able to roll out an integrated care model. So just to point out a couple of the key features of what is involved with this model, really one of the main things that the Cherokee FQHC created was that they had consulting psychiatrists and other behavioral health providers that were directly embedded into primary care teams. So they were really working hand in hand with these primary care providers, so that they really were very aware with what was going on with the patients. Getting patients connected to care was as simple as going across the hall versus having to drive to a separate location, call and make a separate appointment. It made the access to care much quicker, as well as a lot smoother because they could easily communicate amongst the team. With that, they had their own shared support staff. They had very clear clinical workflows and referral processes. I'll talk about this a little bit more, but one of the issues with between primary care referrals to behavioral health is not always understanding what the role of that provider is. And so not understanding what the workflow, the referral process is, can make that much smoother to ensure that they're getting connected to the right type of behavioral health provider that they need. And then lastly, they had that shared communication and treatment planning. So they were able to directly communicate with the other teams, as well as be able to work out a treatment plan for particular patients with one another versus doing them separately. Now, I will note that this integrated care model, the way that it was built to be all on site. So for the purposes of this program, what we were doing is we were going to adapt this particular integrated care model. This chart comes from a partnership between SAMHSA and HRSA, who came up with this chart. But we were going to adapt this in-person brick and mortar type of model into a virtual model. And so you'll see that most of this is referencing on-site. We are kind of adapting it virtually, and I'll explain a little bit more how we're doing that here shortly. But all of the partners that we had identified to work with on this particular program would have fallen into that level 1, level 2. So either very minimal collaboration or very distant collaboration between their behavioral health providers and their primary care providers. Now, I will state that some that we were going to work with didn't even have behavioral health providers. And so in order for them to even move past level 1, they first needed to have access to those particular types of services. But some of the things that are characteristics for that level 1, level 2 is that they have very separate systems. They very rarely communicate about cases with one another. It's usually under very specific circumstances, and it's very, very rare. And they usually never meet one another, and they really don't understand what each other's roles are. So really one of the goals through partnering with those healthcare providers is to move them closer to a level 5 integrated approach. And so really being able to see where they were seeking solutions together between the primary care and behavioral health teams. There's frequent communication and collaboration, as well as frequent meetings so that they could actually work out those treatment plans with one another. So the way that we were going to adapt this to be a virtual model versus the brick and mortar model is that we want to ensure that any direct-to-consumer telehealth services that are being provided are going to be provided on the same direct-to-consumer telehealth platform. This is going to make it a lot simpler in order to be able to refer or transfer to other providers, as well as make communication amongst those providers a lot more seamless versus if they're on 2 separate direct-to-consumer telehealth platforms. Additionally, we're going to convene virtual multidisciplinary roundtables. This would give these different teams an opportunity to really work on those different treatment plans for patients and to have a frequent meeting to where they actually understood what each team was working on. And then lastly, we wanted to hold recurring virtual annual meetings to collect feedback on the virtual integrated care model. Now, a lot of this goes back to the quote from Cherokee where it says, this is not just a program, it's a culture. So we really want to be collecting that feedback from the providers who are doing the work to ensure that ultimately this model works for them and is starting to become a part of the culture rather than a program that they're having to be compliant with or work on. And so that's a little bit of an overview of the integrated care model. Now, I want to spend a little bit of time for those of you who may be on the webinar who already have a telehealth program, or maybe you're looking to develop a new telehealth program. I want to walk through the process of how we ultimately designed this program and how we set up to evaluate this program, because both of those will be essential whenever you're starting to start a new program to be able to have a clear vision and a clear way that you're evaluating outcomes. So in general, when you're looking for a telehealth program, there are some best practices to follow. And so first off, you want to be able to identify a focus area. So with a Crossroads program, we have one that's focused on telebehavioral health and one on telestroke. So as Bryce said earlier in the presentation, all of our partners are located in mental health professional shortage areas. And so it was very easy to find this is an area where a need needs to be met and a new telehealth service needs to be placed in order to help meet the needs of the patient. Similar with our telestroke, all of our partners did not have access to those particular specialty services in order to be able to provide that level of care for patients. And so that was an area that we could identify as a focus area to help meet a need. So really you do that by following the data. So can you see what are some of the health professional shortages that you're experiencing in your area? What is some of if you have access to electronic medical records, can you see what are some of the conditions that maybe could benefit from a telehealth program? So being able to follow the data to help influence that focus area is really key to be able to make a successful telehealth program in the future. Additionally, you might be able to collect feedback. So either collecting feedback if you're an administrator, collecting feedback from your frontline staff, or collecting feedback from patients. What are some of the cares that they want to see offered through a telehealth format? And what are some of the gaps that maybe some of those frontline healthcare workers are really seeing that could be addressed by a telehealth program? Now, likely through some of that research, you're going to see a million different problems identified. So really, you're going to have to start to sort some of those and prioritize those problems. And really, to prioritize them, you're going to have to be able to envision those expected outcomes. So what are some of the things that you want to address that either there's already been some research that's been done, or that has a clear connection to some of those outcomes that you're expecting? Because this will really help you to be able to set appropriate expectations for your program, in order to build a better evaluation so that you can really look at the impact of your services. And so those are just some general best practices if you're looking to implement a new telehealth program. That's kind of the thought process from the early stages to really be able to get the ball rolling. Next, when you start to look for whether you're looking to do this in your own organization or whether you're helping others be able to implement a new telehealth program, you really kind of have to figure out if the culture is a right fit. And there's a few ways that you do that, but one of the first and most important ways is that in that organization, you need to identify who your telehealth champion is. So that's really going to be your biggest telehealth cheerleader, advocate in that organization that's going to be ultimately pushing for those things to move forward. And they're also going to be able to give the best feedback when it comes to the corporate willingness in order to move forward on this new telehealth service line. And so once you identify that telehealth champion and you can define some of this corporate willingness, you can start to develop a plan. And so there's lots of different things to think through, but really some of the main things is the legal or regulatory constraints that need to be thought through first, as well as being able to have a very specific work plan that you can modify any existing procedures or add any additional training for staff and to slowly roll it out. There's a lot of instances when you have to roll out a new program and it requires multiple healthcare professionals to have to completely redo how they do care. It can be really overwhelming. And so being able to trial it slowly and be able to roll it out in a more large scale format kind of over the course of time is just going to improve your success for the program long term. And then lastly, once you develop that plan, that's when you start to implement and you start to monitor. And so one of the most important things is that you need to have a very clear evaluation framework and truly understand what are some of the outcomes that you want to see from this program long term. So now kind of rolling back into our program, those were some of the things that we thought through when we were designing the goals for this program, as well as we were identifying partners for this program. And so our first goal was a relatively obvious goal, and it's to expand direct-to-consumer telehealth services for primary care and behavioral health to underserved patients living in rural communities. And so that's where we were offering an annual stipend of $20,000. And this is really to be used to offset staff time, equipment costs, or any costs that come with implementing those new behavioral health services for partners that maybe didn't have those in place before. Now, as a HRSA funded entity, we take a vendor agnostic approach. And so there's a lot of advantages of we can come from a very unbiased perspective and be able to connect different partners to different technology, vendors, or provider networks if they're needed. Then lastly, the Crossroads staff and the UMTRC staff are able to offer that technical assistance for any implementation needs that come up as they're implementing the new program. So the second goal is to really build partner capacity. So we don't want to come in, offer a program, ultimately for that program to disintegrate as soon as grant funding ends. And so there's kind of a, we also want to make sure that that integrated model can be something that can be sustained long term. And so really there's a few different ways that we're doing that. And so one is looking at different integrated care timelines for each site. Each site is kind of coming from a different phase. If you can think back to that chart of 1 to 6, each is kind of coming from a different point on that chart. And some, because they don't have the behavioral health services in place already, are definitely going to be going to need a more generous timeline on the front end to be able to really meet and start that integrated care model. The second is that we were contracting with Purdue Healthcare Advisors to train 2 telehealth champions from each site in strategic doing and lean daily improvement methodologies. This is really to be able to help build capacity of staff to be able to implement and evaluate new programs as they come up. And so we wanted to be able to provide that very specific training in order to help build the capacity for each partner to be able to maintain their telehealth program or to be able to start a new one in the future. Then we wanted to create more defined workflows, roles, and referral processes. So that's something that can be used long-term for each one of those partners, as well as developing those multidisciplinary roundtables and the annual meetings where we're getting feedback from those providers. And then lastly is the data collection and analysis. And one of the big focuses for the Crossroads Partnership for Telehealth, as well as the UMTRC, is being able to utilize data in order to show the effectiveness of telehealth services on meeting the needs for patients. And so within this program, really, we're collecting data from each partner site. And this is done through a couple different ways. It's either done through remote access into the EMR by Crossroads staff. And so typically what partners will do is they will give us a medical record number of patients that received the particular telehealth service that we're looking at. And Crossroads staff will use that MRN in order to look up that patient data and pull the particular metrics that we're looking for. However, there are some that prefer to pull that data themselves. And so they will actually pull that patient data for anyone who received the service, and then they'll send it to our staff through secure email. For the purposes of this program, we wanted to be able to separate patients into a control group and an experimental group. Control being patients who are receiving in-person care versus the experimental is those who are receiving the direct-to-consumer telehealth care. And we don't want to just collect data just to collect data. And so one of the main things we want to offer to our partners is to be able to provide data snapshots so that they can see what are some of the trends in their telehealth programs utilization, what are some of the outcomes of their program, and to be able to condense that into a simple format to be able to show this is what you're seeing, and maybe these are some ways that we can improve the program kind of moving in the future. And kind of with that, when you're going to build that evaluation design, a good framework. So when you're designing that evaluation and how we design this evaluation for the Crossroads program, a big part of it is going to be the Institute for Healthcare Improvement, the triple aim or the quadruple aim, recently the quadruple aim, but really looking at these 4 different areas of how is this telehealth program ultimately meeting all of these different areas of the quadruple aim. So in the patient experience, population health, reducing costs, and care team well-being. And so we really want to be able to build our evaluation amongst those 4 aims and seeing how our program is ultimately meeting each one of those. And when it comes to a general evaluation framework, really one of the main things that you want to do as when it goes back to the best practices is it kind of starts with that community assessment. So what is the need? Where is the need? what is the best type of program to meet that need, and really being able to follow the data in order to get that will lead into, this is the type of telehealth program or initiative that I want to develop. And so once you decide that program, that's when you begin to design the evaluation. Within the Crossroads program, that was looking at the quadruple aim, the collection of the data, which is where we're getting the remote EMR access or the secure emails from our partner sites. And then we analyze and interpret that data, which we're doing through our data snapshots, and lastly, reporting the findings. So being able to condense and report out, these are some of the outcomes that I had from this particular telehealth program. And so that's a very general evaluation framework that can work in lots of different scenarios, but can kind of help you as if you already have a telehealth program or are looking to implement one, how you kind of design that evaluation framework. And I wanted to point out this quote from the Institute of Healthcare Improvement, which states, "Measurement is a critical part of testing and implementing changes. Measures tell a team whether the changes they are making actually leads to improvement. Measurement for improvement should not be confused with measurement for research." And so the reason I point this out is, even within these telehealth programs that are being implemented, we don't want to just implement telehealth programs and kind of hope that they're doing what we want them to. We want to be able to clearly quantify, either through quantifiable data through numbers, different results from patient EMRs, as well as qualitative data, feedback from providers and patients, to be able to really demonstrate this is how this telehealth program is having impact. And, not just kind of blindly throwing a program and kind of hoping that it does what you want it to. So the measurement piece is very critical, especially within the context of these telehealth programs. They're still very new, and a lot of research is being done in order to show their long-term effectiveness. So I'm not going to go through all of these individual measures. I just wanted to be able to show you, these were some of the metrics that we are collecting from partner sites. And so you'll see that we kind of broke them into different categories. So one being clinical outcomes, or we're looking at things like biometric values and prevalence of chronic conditions. Then we have cost effectiveness. So what are ways that this direct-to-consumer telehealth program is reducing costs, quality of care, and then lastly, access. So how is this direct-to-consumer telehealth program improving access for rural patients who are receiving the services? And then we did break into particular measures with, as Bryce said earlier in this presentation, we had secondary focus areas so that partners can choose to focus on related to maternal health, chronic care management, and substance use disorders. So thank you so much for joining us, and we hope you have a great rest of your day.